Okay, well, welcome everybody to the second of the GSA COVID conversations. The title of this conversation is, Did the Pandemic Deepen Health Inequities for Minority Older Adults? It's great to have everybody here. Very important topic. We have an excellent panel. Let me begin by introducing our GSA staff here who's helped so well with this webinar series. Elizabeth Sobchik and Judy Liu are on our call. Elizabeth is going to walk us through some of the background to the COVID conversation series. Elizabeth, please.
Thank you. So I'll just start with a little bit of housekeeping. We'd invite you all to introduce yourself in the chat. We'd love to get to know your name and who you're with, what institution or organization. So please go ahead and start putting that in the chat. You're also welcome to use the chat box throughout presentations to comment, to ask questions. If you have any technical issues, please flag them there and we will try to help resolve those. We are recording this conversation and it will be archived on GSA's website. We do have a couple of future conversations, and so we'd invite you to join in and invite your friends to register for those. We'll show you the link for both the archived conversations and registration. It's all on the same page in just a couple of slides here. And then we'd also ask you to keep your audio muted during the discussion. You're welcome to keep your video on, but please keep your audio muted. Really quickly, I'll just run through what sort of got us to this point with the COVID-19 conversations. Last year, in March of 2020, we started seeing the disproportionate impact of the pandemic on older adults, and GSA leadership formed a task force. The objective was really to stay apprised of what was happening in the pandemic, to reflect on what was happening, and then to prioritize the tools, resources, and things that were needed to support GSA members. So one of the pieces that the task force members developed was a research agenda. There were 12 areas that they felt like we needed to better understand and continue to research for the pandemic's impact on older adults. And from those conversations and looking at how much was published in GSA journals, which is linked from the slides here, we started the COVID conversation series. So we combined what our members have been researching as well as areas that we think need further research to bring to you experts in the field who are going to be talking about these specific areas. So our first one was, how bad was the pandemic? That is archived on the GSA website. Did the pandemic deepen health inequities is for today, and then what worked and didn't work in response in September. That link down at the bottom of this slide will get you to all of the conversations to either view the archive or to register for them. A really simple trick is to go to geron.org/COVID-19. And then on the right-hand side, there's a conversations tab that you can click on, so you don't have to remember that long link. Our panel today is ready to go, and so I'm very pleased to turn things back over to Dr. Albert to take us through the discussion today. Thanks all.
Okay, thank you, Elizabeth. So here's our panel, Dr. Bella Chavola from Mexico, Dr. Emily Sun Yuan from Texas Tech University, and Dr. Karen Lincoln from USC, a great panel covering many of the dimensions that we're going to cover today. Let me give just a little background before we turn it over to our speakers. So this session is dedicated to the challenge of COVID for our minorities. Bad as it has been for older adults, the pandemic has told even more heavily on older people of color, as well as immigrants, the rural sector, and older people in low and middle income countries. Older minorities face many challenges compared to majority populations. We have an increasing set of data on differences in incidence, mortality, hospitalization, and ICU care. And more recently, we've seen evidence of less access to testing and vaccination among our minority older populations. There is also evidence for greater difficulty obtaining services during pandemic restrictions, and maybe even worse outcomes for the effect of lockdown. So that's a little more controversial. So we want to take a look at some of this today just to whet your appetites. We're going to come back to this topic, I'm sure, in future conversations. But let me give you a little bit of the data that we do know just to set the scene. We can look at the CDC Covid Surveillance, and we see there that age standardized rates suggest that minorities face double the risk of death and nearly 3 times the risk of hospitalization due to COVID. And I just have to mention a particular challenge and an annoyance in my mind that CDC has race and ethnicity data only on about 2/3 of the cases of COVID that are in our surveillance databases. And why we lack race and ethnicity data is a topic worth separate discussion, which we can't get into today. I'd also want to add that it's Native Americans, at least in the United States, who have the highest excess risk in incidence, hospitalization, and death. But our other minorities are not so far behind. We also have an interesting take on this. Why is it that minorities should face excess risk? CDC answers that it's really a social determinant question. As they put it, conditions in the places where people live, learn, work, play, and worship affect a wide range of health risks and outcomes, such as COVID infection, illness, and death. Well, that's the kind of thing we want to look at today. Okay. Just to show you one other slant on this whole thing, these social determinants are something we're beginning to learn more about. One very interesting study in Health Affairs, the journal, defined high exposure risk households to capture these social determinants. And they defined a high risk household as one with 1 or more essential workers and fewer rooms than inhabitants. So that was their definition of a high exposure household. And if you use that definition, Latinos in the United States were overrepresented in cumulative cases and underrepresented in testing. I should say that was in California. These kinds of disparities extend themselves as well to vaccination. We know from a recent Kaiser Family Foundation report that Black people in the District of Columbia received 43% of the vaccinations, but make up 56% of the cases and 71% of the deaths. So these disparities are legion, and we really need to ask ourselves why they happen and what we can do to address them better. So that's what we want to discuss in our webinar today. I'm going to turn it over now to our guests. They're each going to take about 7 minutes just to describe some of their research in this area. And then I'll follow up with some questions, and then it'll be your turn. Those of you listening in to the webinar, I hope you'll lodge a couple of questions in the chat, or perhaps be willing to open your microphone at the end to ask questions to our speakers. So let me begin with Dr. Lincoln. Let's have a summary of your work on minority aging and health, and maybe set the scene for us.
Sure. Well, thank you for having me. I'm very excited to be here, especially given the discussion around social determinants, because that's pretty much where my work resides. So I am a social worker. I'm also a sociologist. That is my expertise. So I tend to look at the world through a lens from societal level factors and social factors. My expertise is in social relationships, excuse me, and psychosocial stress. And I'm interested in those things and how they can protect against mental health problems and health problems. I'm a health disparities researcher, and so I'm looking at disproportionality. So as you mentioned early in the introduction around the disproportionality in terms of rates, infection, vaccination, et cetera, among African Americans and Latinx populations and Native American populations as well, that's what I'm preoccupied with. And to that end, the goal of my work is to improve access to acceptable and sustainable types of interventions and treatments for communities that have high risk and are generally underserved. And that includes African-American older adults, African-Americans across the life course. I've done work with Latinx communities as well as Asian American communities. I'm particularly interested in those who have limited access to health protective resources. So I published pretty widely in this area. It's about 70 or so publications looking at disparities in health and mental health. One of the key features of my work is looking at heterogeneity. And so in looking at the Black American population, for example, I'm interested in immigrant populations within the Black American population. And so, we don't talk a lot about Black ethnicity, but clearly we are an ethnic population as well. We have people who were born in this country and born outside of this country. We have immigrants, people from different parts of the diaspora who are part of the population and have very different risk and protective factors, very different cultures, different languages, and different outcomes. And so my work highlights some of those differences. So just to feature a couple of pieces of my work to sort of provide some examples, I did a paper that looked at Caribbean Blacks and sleep and depression. So what the general literature will tell you is that African Americans have the poorest sleep quality in the United States, and that is true. But if you start to look at different subpopulations within the broader population of Black Americans, you start to see some differences. And so I'm always interested in not just identifying those who have the highest level of risk, but also those who are doing well, right? Because that's where the intervention points are. And so that's why I examine a lot of these accessible resources in terms of social relationships and connections, because we can make adjustments in relationships, right? The other thing I'd like to highlight as it's not out yet, but it will be coming out. It's a piece focused on cognitive status and looking at social relationships. And I wanted to contribute to the literature that connects social connections to cognitive status. And so in this paper, I wanted to look at different sources of support among African Americans, and what my findings showed was similar to, well, actually, unlike what's been reported in the literature, whereby more diverse social networks, having different people in your networks from different sources, different types, lead to better cognitive status. I did not find that for African Americans. I actually found that friendship networks, people who have networks that are primarily comprised of friends, but also have family members, also have children, also have spouses, actually fare better in terms of their cognitive status. Those who had restricted networks, who were more socially isolated, there were no findings there. And so my work is really to sort of contribute to the broader literature by showing differences within populations, differences in risk factors and protective factors, and the variation of all of those things and the combination of all of those things. And finally, I wanted to talk a little bit about my public scholarship, because that's where most of my COVID research and information lie. I'm an avid public scholar. I love writing op-eds. I've written op-eds for the New York Times and the Wall Street Journal. And that's where I can take my research and disseminate it to a lay audience. And so that's better, it's more digestible and understandable. And so one of my recent pieces that focused on COVID did talk about social determinants of health, but it really focused on racism, right? So we talk a lot and heard about a lot about underlying conditions being the primary reasons why so many African Americans have high rates of infection and death due to COVID. And yes, social determinants, where people live, where people work, where people age, all of those things are really important, but those things are primarily determined by these larger structural factors, right? Racism, racial segregation, right? Forcing people to live in certain neighborhoods, restricting access to these health promoting resources, determining where people can go to school, where people can work, right? So looking at racism as the underlying factor that's sort of helping us understand these disparities in COVID outcomes. And then finally, I want to end with the work that I do in the community. So I founded a program called Advocates for African American Elders. The goal is to provide health education to older adults in South Los Angeles. So we use a number of mediums to do that, infographics, talk shows. Everyone likes a talk show. So instead of PowerPoints and webinars, we actually have conversations to share very interesting, important information to improve health outcomes, to link people to resources, and to improve education, particularly in Alzheimer's disease, which is really prevalent in many African American communities. And so I actually designed an intervention called BrainWorks, where we used a talk show, and we used text messages to increase Alzheimer's disease literacy, because African Americans overall have very low levels of literacy, but very high levels of Alzheimer's disease. And so part of my work in terms of my empirical work, my community work, and my public scholarship all sort of coalesce around the idea of improving access to responsible, appropriate, relevant, and accessible sustainable treatment. And so that's the general summary of my work.
Terrific. Thank you very much. Okay,
Welcome.
Dr. Choi, please give us a little background about your interests and also your work on COVID.
Okay, hello, and thank you for hosting this timely conversation. And I'm happy to be a part of the panel today. So I am a sociologist and demographer, and I'm especially interested in social determinants of health and racial, ethnic, and geographic disparities in health, especially among older adults. And the study, the I would like to especially share today in terms of COVID is about the regional disparities in COVID-19 infections that focuses on county level aging populations. So COVID-19 hit hardest older populations in the US, and the likelihood of fatality greatly increases with age during the early period of the pandemic especially. However, the field studies directly examine the patterns of the COVID incidence in older populations. And many previous studies have focused on only certain regions or just a particular populations rather than nationally representative units like counties. Also, there was a growing concern about the spread of COVID in rural counties because the proportion of older population is higher in rural regions than urban regions. And also the rural residence is associated with overall health disadvantages in later life, such as lower life expectancy, higher morbidity, and lower insurance coverage rates, and so on. So to fill the gap, my study was among the first to examine how areas with the different older population compositions were affected by COVID, and whether urban and rural counties face different challenges and different paths of infection. To answer those questions, I used the national county level data, including 3,042 US counties. And my dependent variable was the number of confirmed COVID cases in a county as of late June in 2020 last year. And the key independent variable was the proportion of older populations aged 65 and older of those counties. I categorized it into low, medium, and high ratio of an older population. Then I tracked the COVID confirmed cases in both urban and rural counties over time, since the first confirmed case for each county. I applied a negative binomial regression to the data to estimate the relationship between older population ratios and the number of confirmed COVID cases, and how this relationship changes over time in both urban and rural counties, and compare that. So my findings suggest that, well, as expected, the older population ratio has a significant yet complex relationship with COVID incidence rates. First, especially among urban counties, counties with a low older population ratio experience the highest number of confirmed cases of COVID, especially at the beginning of the pandemic. However, they hit their peak of the infection after 1 to 2 months after their first confirmed cases. And the prevalence slows down after that quickly. By contrast, confirmed cases in high ratio urban counties, which means that over the 25% of their total population is aged 65 and older, increased exponentially with time rather than slowing down. And among rural counties, those with a high older population ratio hit their peak much later and recover more slowly compared to other younger rural counties, which has the highest prevalence of COVID at the early phase of the pandemic. So in short, I found that the population aging and the age structure of counties had a significant association with the spread of COVID. Both urban and rural counties with larger older populations are more vulnerable to COVID than counties having younger populations. And those disadvantages in COVID infections are more rapidly exacerbated over time in urban counties. So the findings suggest that it is very important to take an early action in those older counties, especially in urban areas, for effective intervention and prevention. Thank you.
Very good. Thank you very much, Dr. Choi. Okay, Dr. Bella-Chavola, please.
Hi, yes, thank you very much. And I'm very honored to be part of this panel. Our research group actually focused a lot on trying to understand how the COVID pandemic behaved in Mexico. We focused on a broad range of topics, but we're particularly interested in how social inequalities actually played a role in shaping the course of the COVID-19 pandemic. We're actually observing this early on the course of the pandemic. At the very beginning, all of you might remember that the situation in Lombardy was quite dire, and that we were observing that there was a lot of ageism in how decisions were being taken in relation to the care of COVID-19 patients. So that was worrying because we were just starting to have a large wave of COVID cases in Mexico. And it was concerning because, of course, the hospital capacity and the availability of beds is significantly lower in many areas of Mexico compared to even the least developed areas in Europe. So we were wondering at the beginning of the pandemic how it was going to affect older adults. But when we were actually thinking about the study, because this was actually possible because of an open data policy in Mexico, we were wondering whether the pandemic was actually going to impact significantly more older adults. And that is interesting because Mexico has a very different population structure compared to many countries. We have a very fat tail amongst 20 to 40-year-old subjects, and a lot of them actually have a wide range of comorbidities. So as you know, Mexico has a very high rate of type 2 diabetes, and those rates of type 2 diabetes and obesity actually influence COVID-19 outcomes. So taking all that into account, we wanted to devise a study which would simultaneously analyze some of the particularities of the metabolic burden of Mexicans and also include social determinants of health. So we analyzed actually older adults, so those older than 60 years, who acquired COVID-19 at the beginning of the pandemic. So we were talking the months of April, May, and June. And we analyzed how different aspects actually influenced the outcomes of these patients. And that was interesting because we wanted to contrast the impact of chronological age. So our research group, besides doing COVID work, actually works with biological age and chronological age and how those two complement each other. And the hypothesis that our research group was working on is that the high burden of metabolic comorbidities was actually increasing the biological age of Mexicans, and that this increasing biological age was actually contributing to worse outcomes. When we included social determinants of health, we found something very surprising, and that was that comorbidities aside, social determinants of health actually explain a larger proportion of the risk of COVID-19 outcomes, or the adverse outcomes, compared to just chronological age. And that was something that was not really surprising, but it was interesting in the sense that we were expecting that comorbidities played a larger role compared to just considering the social determinants of health. Now, if we actually consider the individual municipalities in Mexico, so if we look at the smallest towns in Mexico, which would be the equivalent of a county in the US, we actually wanted to see how these actually differ. So if you look at clusters of these states, some of the largest burden occurred in the cities, and we actually showed this in a later paper that we published this year, where we showed that one of the main determinants of the pandemic was actually social inequality, and that this was actually larger for older adults. And this was interesting because we often think of Mexico as a very unequal country, right? But we often associate it with just the economical impacts of this. And what was interesting is that despite the fact that perhaps the risk of infection was higher in some areas which have higher income, for example, Mexico City, even within Mexico City, the areas with the highest social inequality, particularly those older adults who had social inequality, who had occupations which prevented them from actually having social isolation, had a very strong role in shaping the pandemic. So the Mexican government actually implemented a few very minor policies to try to mitigate this effect. So we have a strong stipend that we give to older adults every 2 months, and they actually made some advancements during the pandemic. However, as shown by our data in the study published in the journals of gerontology, and also the study we published this year, a lot of the influence of COVID, a lot of the impact of COVID was actually in those older adults who were not able to self-isolate. So there were mandates for social isolation, but these older adults were not able to comply with it. And that actually was associated with a higher risk of mortality. Similarly, we also observed that the risk of mortality was higher for older adults who stayed at home. So we had a very steep peak of COVID, particularly during May and April. And what we observed is that during these times where hospital capacity was severely reduced, a lot of older adults were actually dying at home. And what was very worrying in this sense is that they were not only dying at home, but they were dying at home in the poorest municipalities in Mexico. So what we were observing is that it wasn't just chronological age, because a lot of these older adults were actually in the younger spectrum of the older adults. So they were, say, 60 years old, and we had a lot of survivors over 80 years old who lived in more well-accommodated areas. So what we concluded in this first paper that we published in Journals of Gerontology was the structural factors, when considered along with comorbidities, actually provided a greater predictive capacity for COVID-19 outcomes compared to just chronological age. And this was a strong evidence that we shouldn't just consider age as one of the main determinants to establish risk. However, one of the main risks, and this was the complement that we observed in the paper we published this year, was that social inequality is one of the strongest risk factors. However, it is non-modifiable in a larger sense unless there are government interventions. And as we also showed in the paper we published this year in Clinical Infectious Diseases, unfortunately, the policies by the government were unsuccessful in mitigating these inequalities. And this is a large part of why this was a huge problem in Mexico, why the ex-mortality is so large, and why the death toll ended up being so high. Because despite the fact that there were interventions, they were not specifically tailored to the communities that were being applied in. And this really didn't help, because social inequalities are not something that you just erase or that you just don't consider. And another different part is in Mexico, we have indigenous persons, and those indigenous persons actually also had a larger death toll, particularly older adults who were of indigenous origin. So as we can see, ethnicity, social inequalities play a larger role than chronological age in Mexico. And this is something that we still see even with the Delta wave right now. Thank you.
Very good. Thank you. Thank you all. Terrific span of expertise and topics. We really have covered the terrain quite well, although of course it's much larger. But I think we have a really excellent panel here. Let me begin now with a couple of questions to each of you. I hope you'll all feel free to chime in if you have a thought. But let me begin with Dr. Lincoln first. In case people don't know, you've just been elected as vice chair to the GSA Behavioral and Social Sciences section. Congrats.
Thank
And
you.
I want to put in a little plug. You're a very loyal citizen to GSA, serving as an associate editor for our journal Innovation in Aging, which I edit, and appreciate that as well. So let me throw out an impossibly large question for you first. Okay, is COVID a new or different kind of threat to Black American mental health and well-being? Is it something we haven't seen before, or is it more of the same?
You know, that's an interesting question. To some extent, it's more of the same, right? When you have a disaster, right, of this proportion, we tend to see disproportionate impacts on African Americans. I will say, though, that it's new in the sense that it affects the entire world, right? It affects all of us individually. It affects us as families and communities. And the new aspect of it, I think, is not just the persistence of this pandemic, but the span of it with respect to how it impacts African Americans. So of course, you know, we are suffering from disproportionate infection rates and death rates. Our families, our communities, our friends are impacted, which lends itself to a ton of grief. I mean, the inability to mourn and to be there when your loved one dies and to bury them in our customary ways is very stressful. Just the loss that we're experiencing certainly has huge impacts on our mental health that I don't even think we understand and can foresee at this point. But the other thing that makes this a bit new is that in addition to all of that, it's impacting our way of life. You know, many people have suffered unemployment, food insecurity, economic insecurity, homelessness, people, you know, who are essential workers are either losing their job or risking infecting their families. And so I think and then the churches, sort of social distancing and not being able to attend churches and to gather, right? Some of the more traditional sources that are really important for us that help to maintain and restore our mental health have been taken away, right? And so I think it is new to the extent that it has really attacked those protective sources that we typically rely on to support us through these difficult times, and has certainly increased, you know, some of the economic and social disadvantages that are already sort of rampant in many of our communities. And I think that, you know, many of us are not going to be able to recover from those effects.
That's an excellent distinction, that it's maybe different, and that's COVID is particularly threat to the protective factors we often rely on when we face other disasters. What about the variation that we've heard from our other two speakers, that were there some components of the African-American community that did better or worse? For example, I know you've done research on Caribbean populations. Do you see that kind of variation in the impact of the pandemic?
There is some variation. You know, income is only protective to an extent, right? And I think one of the things I would like to highlight, since we're having this discussion, particularly because my work does focus on heterogeneity, are Black immigrants. You know, we don't talk a lot about Black immigrants in the United States, but, you know, Black immigrants there's more than 4 million Black immigrants in the United States. And, you know, I really like to highlight the fact that many of them reside in some of the states that have been the hardest hit by COVID, like New York and in Florida, Georgia, Atlanta, in particular in the DC area. And so, you think about Black immigrants who are already facing deportation. We don't talk a lot about that, but even during sort of the surge at the border and people being detained, a lot of Haitian immigrants were deported. We didn't really sort of hear about the Black immigrants who were coming also with the swell of Latinx populations who were being deported back to Haiti, for example. But in addition to these hard-hit populations with these Black immigrants and deportation issues and concerns about that, we also have to remember that many of these Black immigrants are working in the essential workforce, right? Many are in home care. Most of our home care workers are BIPOC women, and a third are immigrants, and many of them are Black immigrants. And we lost about 340,000 home care worker jobs last year. Due to childcare issues, due to being laid off or fired, concerns about COVID and actually getting COVID. And so many of these immigrants were impacted by that. And then one last thing I'd like to mention about immigrants is remittances, like different from African Americans. We do sort of send money and share resources, but many immigrant families, Black immigrant families, rely on their family members who are in the United States working and them being able to send money home. But when you have this global pandemic where everyone is impacted, right, across the world, even in people's home country, people who are losing their jobs can't support their families at home. And so the impact is just, it's huge. It spans from an individual to their home country, to their families. And so I think just to highlight and raise up our Black immigrants who have suffered not disproportionately to other Black Americans, but differently. And these are some of the different factors that we should consider with our Black immigrants that we don't typically capture in the data, because as you said, Steve, where we have like a big significant sort of proportion of cases where we don't have race data.
Right.
And then we have Black categories with all these immigrants in there that we haven't really designated. So we have a lot of unknowns in terms of how Black immigrants in particular are being impacted by COVID because we don't have the data. But we do know their circumstances and some potential impacts of COVID that we can probably assume, but we can't yet prove.
Right. Well, you're making an excellent case for better public health statistics and surveillance, which I appreciate. Let me turn to one other thing you mentioned a little while ago. I think you're involved with a self-help kind of community mobilization effort. And I know this has been very important for minority communities throughout the pandemic. I can speak with a little knowledge of what's happening here in Pittsburgh. I'm at the University of Pittsburgh, and many of the Black communities felt that they just did not have access to testing. They didn't feel they were able to social distance the way some more affluent communities were doing. They were more likely to have essential workers and need to use public transportation. So a number of self-help efforts took off. A lot of community organizations put together, I think they were called health deputies here, to check in on people, deliver food, guide people to medical care early on in the vaccination period, give people little inside information on how to get a timely vaccination. What are people studying this? And maybe you yourself, or maybe some people I mean, this seems to me a terrific illustration of older people in communities organizing for their own well-being.
Right. Yeah, we participated, with Advocates for African American Elders. We didn't collect data per se, but we did contact our community partners to find out, what do our older adult residents need? Excuse me. And to our surprise, it wasn't food. It was really hygiene kits. People needed masks and disinfecting, products and wipes, et cetera. And so we pulled our resources to put together what we called hygiene kits. And we put them together and disseminated hundreds of them to community partners who were working with older adults so that they can deliver them through the meal services every day to the most vulnerable older adults. And so, there was no research involved, but we certainly were able to act quickly because of our relationships in the community. In terms of research, I know NIH has done some work and funded a number of PIs across various states in their SEALs program. It's a community engagement and alliance. And so the goal of those research projects is to work with community. It's community engagement, sort of focusing on community education around COVID. There's a Community Vax coalition, which I think is awesome. They are also focused on community engagement, and it is research funded with PIs across the country. The goal of both of these programs, particularly the Community Vax, which I really like because it centers people of color, right? People of color are at the center. So you have these researchers, right? I'm one of them. But with my program, I'm the only academic. Everybody else is from the community. And so I really appreciate these community engagement coalitions because they're working with researchers, but they're primarily focused on people on the ground and using ethnographic methods to really understand not only the needs of these communities, but how people are responding to them. And then being able to disseminate that information in reports so that we can not just find out, the needs, but to see how people are able to use their own resources that are culturally relevant, that are accessible, that are meaningful, that are sustainable to respond to the COVID, either whether it's increasing vaccination rates or, sort of dealing with some of this misinformation that's spreading in our communities. And so I think those are the key, points that we want to highlight is that communities know what to do, right? We just need to make sure that communities are involved in the solution. They're not just on the receiving end of all the bad news, right? There's a lot of solutions that can come from that, and resources should definitely be deployed to those communities who really know how to solve their own problems with just some support. So I think that's what we've learned from a lot of these studies.
Very good, thank you. We can come back to some of these, I hope, but let me turn to Dr. Choi now and your study. And you make the very good point that rural counties in the US are older on the whole than urban counties. I think I'm right in saying that. And this is not just in the United States, right? I think we see this in other countries as well, like Japan, for example. So I could see why you started to think that COVID may differ on the basis of rural versus urban, but also you have variation in age composition and many moving parts because you have time trends. Yours is a complicated study, I would say, but I really enjoyed reading your paper. What led you to focus on the rural-urban differences? Because there are many other kinds of comparisons we could do.
That's a good question. So as a demographer and social gerontologist, I have long been interested in older populations in this country and their spatial distribution across the country and regional disparities in their health outcomes. And especially the reason why I investigated the rural variations in COVID was because, well, since the onset of the pandemic and its progress, most of the studies, policymakers, and the media only focused on at-risk older adults living in metropolitan cities like New York City and urban areas. Well, the urban focus back then makes sense because those areas were the epicenters of COVID back then, especially during the early stage of the pandemic. However, as Dr. Elbow just pointed out, the rural counties or areas in the US or in the world have much greater numbers of older populations compared to urban counties. And the rural areas were projected to experience more severe cases of COVID in the long run and suffer longer. So several features of rural older adults led me to focus on this issue. So for example, the living arrangement of rural older adults, such as living alone or with families, or even in a nursing home, are quite different. They have a quite different experience from that of all urban counterparts. And the prevalence of the comorbidities, such as the diabetes or the respiratory disease, are higher, much higher among rural older adults. Plus, they also have a limited access to healthcare facilities near, as we already know. So I became very interested in the regional differences in the transmission of the COVID by older population.
Very good. Terrific. You know, the big question, I guess, here's something I have noticed myself. I don't know if you've looked at the social distancing data from SafeGraph or Unicast. These are surveillance systems that have tracked people's response to the pandemic and how much time people spend at home or how far they go from their homes. I don't know if you've looked at this, but there were pretty interesting differences between urban and rural areas in social distancing as well. Have you brought that into any of your analyses?
Not yet, but yeah, I am aware of such a kind of a new data. Yeah, but back
Okay.
then when I did this research, those data were not available, even though it is a very important factor to see the COVID, the prevalence and the infections. But well, as right now we have a more rich data set about the COVID and social distancing. I'm planning to use those data to further explore this COVID, the infections among older adults or even the county level.
Are you willing to speculate a little bit? Do you think the rural-urban difference will become even more pronounced in our current phase of the infection, or is it impossible to say?
Well, currently, of course, the total numbers of the COVID cases are still higher in the urban areas, the urban counties. But still, if we focus on the race per the population, like the 100,000, well, the rates are even the higher in urban areas. And well, I think one of the kind of important factors about that is the social distancing and the population density. Because the population density is one of the key differences between rural and urban counties. And it's definitely related to social distancing. And it truly matters for the spread of infectious disease like COVID. And that might be why my study shows a much more significant increase in COVID cases in urban counties, even the net of age. So the high population density in urban areas is related to more social interactions in close proximity for older populations, even if it's unintentional.
Sure.
So under those settings, social distancing is more difficult than in rural areas with a lower density. And older adults living in densely populated areas are more likely to be exposed to other people while using public transportation, so doing grocery shopping, and so on. And that increases the risk of a COVID infection for sure. And also, the individuals in the highly density areas tend to experience the crowded living environment, such as having floor mates or roommates. And they also need to share certain public spaces like elevators or the fitness centers at the apartment or the community with others, which also increases the infection of the risk of infection. So again, the population density and the degree of the practicing of social distancing is a really important topic to study the continuous spread of COVID.
Very good. One last question. I'm just curious because I don't know this myself. Is vaccination uptake among older adults in rural areas lower than in urban areas, or do we know this for a fact?
Well, I think yes, it's still going on. The vaccination rates among older adults are maybe still they're kind of higher in urban areas, because the rural areas sometimes it's because of the settings or the preparation, and also the kind of the older adults preference, depending on so many different reasons. So but still there's not much detailed data and why such disparities occurs. So I think that is the area we still need to further collect the data and explore.
Okay, very good. All right, let me switch now then to our Mexican case. Dr. Chavola, you said you were surprised that social determinants turned out to be more important than age, or at least had to be considered in the age-COVID relationship. Are you convinced now, or were you wrong to be surprised?
No, actually, I think, I mean, it was something that we expected. That's why we looked into it. However, I think it was surprising how much of a larger role it actually played in shaping the course of the pandemic. That actually, this preliminary study, which we only focused on older adults, we were wondering whether it was different for other age groups, you know, and we actually undertook the second study that we actually shared right now in the chat box. We actually try to look at how everything, or for all ages, it actually played a role. Interestingly, what we saw is that for younger individuals, the protective age of chronological age, or the expected protective role of chronological age, was halted in the setting of social inequality. And that was something that was very interesting because, you know, when we look at comorbidities, the impact of comorbidities in younger persons offsets by a large margin the impact in older adults, because as we expect, some of these comorbidities actually just pile up to some aging-related changes that just increase the risk of COVID in older adults. But interestingly, social inequality impacts very similarly younger ages than older ages, and they actually offset by a large margin the impact of comorbidity. So rather than say that it was surprising, what was surprising was the magnitude of it. We were anticipating that it played the role, but it has a very large magnitude compared to what we were expecting. And that it happens even in areas where this inequality would not be expected. For example, Mexico City, you expect it to be, you know, the hub of everything, and that, you know, the inequality would probably be lower than some other areas in Mexico. And what was surprising is that this is not the case. The inequality in Mexico City is actually very large. And you can observe it even in any central or urban area, not only in Mexico, but in the US. If you look at the New York data, you see that a lot of this impact on it actually occurs in minorities, in areas where social inequality is actually large.
Right, very interesting. Good point. So I think this is great stuff and very complicated. Do you think there are further lessons, let's say, for Spanish speakers in the United States based on your research?
Yeah, actually, that was something that was actually touched upon in the pandemic in Mexico. We were observing that the areas, particularly areas that have a border shared with the US, for example, the city of Tijuana, or some areas, for example, the one that shares Laredo with McAllen in Texas, a lot of the cases actually seem to be imported at the beginning of the pandemic. And they actually occurred in a larger share in the populations who were actively crossing the border, many of whom actually worked in the US. So what I think happens particularly in Mexico, in contrast to the US, is that some things are better for Mexican Americans in the sense of what is provided within the US. So a lot has been said about the limited testing in the US, but the limited testing is far superior compared to the testing we actually have in Mexico. Actually, older adults are severely underrepresented in COVID numbers in Mexico. We actually pretty much only count cases that are hospitalized or that unfortunately die. And that is something that has a lot of you know, influence when you consider these estimates. When we weighed all the estimates based on the population, we saw that older adults actually have a very limited testing. And that is very worrying in Mexico. In the US, actually, a lot of the data is more evident. So despite the fact that the inequality may be similar, perhaps with the obvious differences in socioeconomic backgrounds and the influence they might have on the testing and everything, the impact of the pandemic is more measurable, with all the caveats, of course, in the US compared to Mexico. So I think that this scenario would be very similar. They share a lot of the comorbidity burden that we have. A lot of the diabetes and obesity related burden is there. There's a lot of social inequality within Latino communities in the US. So I expect that it will behave very similarly, although with this caveat that it is better measured. So we may actually have a better idea of how it works for Latino communities in the US than even for some communities within Mexico.
Very good. Interesting. You know, and one last question for you, and then maybe we can turn it over to the audience here. You make the case that really we have to rely on government and structural interventions, maybe legal, maybe reorganization of medical services or public health services or social services. Do you have a feel for what would have helped, what would help the most, let's say in the Mexican setting for older adults?
Yeah, I think it's a very interesting question, because it's probably the $1 million question, right?
Yes.
What will work best?
Sorry
But I think one of the best things that has happened in Mexico was the vaccination rollout. As it happened in many areas in the world, we prioritize older adults. And if we look at government data, approximately 80 to 90% of adults over 65 years of age are actually fully vaccinated now in Mexico. And with the Delta rates that we've been observing, there's been a slight increase in deaths, but not really as sharp as increase in cases. We've seen that this dissociation in cases compared to hospitalizations is very marked pretty much all over the world. So I think the main strategy was, of course, vaccination. And we actually prioritize in Mexico some areas which have a higher marginalization compared to other areas in the US. I think a second thing that would work, and that it was observed in the US and in some other countries in Europe, are stipends for older adults who have to go out and work, because they have a high exposure risk. Many of these older adults actually work, as merchants, or they sell things, and they get exposed to many people. And if you actually provide a stipend for them to social isolate, then that might actually help prevent them from getting COVID, particularly during pandemic peaks, as we're observing with the Delta wave right now in Mexico. And I think the last part is that we actually, going broader from the COVID area to the whole sense of healthcare, we need to approach healthcare better to older adults, not only in Mexico, but all over the world, particularly in Mexico. We're trying to implement some programs. There is one in Mexico City where actually medical services are taken to the homes of older adults, so that they receive care in home, or that they receive regular checkups. That's something that is expected to reduce at least some of the preventable mortality in older adults. But this is Mexico City. This has to happen all over the country. And Mexico City has a very high access to medical services. So this service is more complementary than really absolutely necessary. Some other areas do not have this opportunity. And developing these programs would be very helpful, particularly for rural areas, taking some of the consideration that Dr. Choi said in the US. In Mexico, it is the same. It is the same for rural areas. There is a lot of older adults who cannot get proper access to care, and who get infected with COVID do not really have anywhere to go. So I think that would be a very strong point to start with.
Excellent. Well, okay, our time is coming to a close. We've spent an hour. Is there a burning question? The chat is full, I see, with interesting questions. If someone would like to raise a question now to our speakers. If not, that's okay, because we really are approaching 1 o'clock. I would like to thank the 3 interlocutors, our speakers. They were terrific. I learned lots today. It was a great lunch hour. I wish we were in person. That will have to be maybe another time. I hope you will continue your research on COVID and aging. And the question I would throw out to the whole audience and all of us together is, we know so much good gerontology. Can we use it well to face a new challenge like a pandemic that at least I haven't seen in my lifetime to this extent? And I think all of you are working on different facets of this. And it really will be very valuable. So I hope we'll be better equipped the next time around. And I hope it'll help us exit from the challenges of this one, which I'm afraid we're still facing. So I think we'll call it to a closure here now. I would only remind everybody 1 month from now, you'll get to hear the third of our COVID conversations on what worked and what didn't work so well for older people. We'll come back to some of these issues, I'm sure. And I would like to thank again all the attendees. I would like to thank our GSA terrific staff for putting this together. And see you in a month. So thank you, everybody. Take care now.